Hello guys, welcome back to Jabstudiesmetfun for Anesthesia Part 2. Before I start with today's video, I would like to remind every one of you that we are going to try to complete anesthesia in 5 to 6 videos. And because of which we are going to state mostly facts. Anesthesia is based off a bit of pharmacology and fact-based things. But in those things which I feel that there is requirement of some explanation, we'll do so. With that information, let's start with today's part for Anesthesia Part 2. We're going to start with a condition which is known as malignant hyperthermia. We have already discussed it in medicine, but let's get a bit more detail in this topic today. First thing you need to know, what is it? It is basically a condition in which a receptor is defective. And what is a receptor? It is going to be a ranodine receptor. This ranodine receptor is responsible for taking in calcium. Because of the mutation in this receptor, too much calcium comes in. And you know that calcium is responsible for contraction. So whenever there is contraction, there is going to be increase in body temperature. There is going to be increase in heart rate. There is going to be increase in blood pressure as well. So talking about it more, the first symptom which you will find is going to be lockjaw. And the lockjaw is going to be because of the masseter spasm. What are the causes? Remember, all inhalational anesthetics along with a depolarizing muscular relaxant which is known as succinylcholine can precipitate malignant hyperthermia. If they'll ask you what is the risk factors will be a strong family history, which means maybe they had an uncle who went into a surgery, and as soon as the patient was given anesthetics, the person had malignant hyperthermia and maybe passed away. Okay. Any muscular dystrophy or any muscular pathology as well. So as I told you, there is a mutation in the ranodine receptor which is present in the sarcoplasmic reticulum, which controls calcium influx. What are the clinical presentation? As you said, calcium is there is too much contraction. Very good. So there will be tachycardia, hypertension, increase in body temperature, and another important thing is increase in end-tidal carbon dioxide. Okay, this will lead to sudden cardiac arrest. Now, why do you think it's going to lead to sudden cardiac arrest? As remember that muscles are contracting. Because of muscle contraction, there will be muscle lysis as well. Whenever there is muscle lysis, there is going to be increased amount of potassium which is being released. And because of hyperkalemia, patient is going to suffer from ventricular arrhythmia, and you know ventricular arrhythmia will cause sudden cardiac death. So what is going to be the management? First thing is cut down all the initial anesthetic or succinylcholine due to which this has been precipitated. You have to give 100% oxygen supplementation as well. The drug of choice for malignant hyperthermia is going to be dantrolene sodium. Okay. Now, other thing we have to know is how do you control the hyperkalemia? To control the hyperkalemia, you're going to have a following management. For acute management, you have to give injection calcium gluconate. That is the main management. Along with this, stuff like salbutamol, insulin, potassium binding resins can be used to bring down the level of potassium. But remember guys, potassium binding resins will take around 2 to 3 days to show its effect. Okay, so remember, drug of choice for malignant hyperthermia, very good, dantrolene sodium. What are the causes? All inhalational anesthetics and succinylcholine. If they ask you, a patient developed lockjaw after the administration of succinylcholine, what are you going to do? The best, as we already talked about, is O2 supplementation. So you're going to give O2 supplementation, which is going to be with help of hyperventilation. You're going to control the body temperature by ice cooling, because you know the body temperature can go as high as 41 degrees Celsius. Okay, and because of the acidosis which will be building up because of the hemolysis as well, the breakdown of muscle as well, you have to give sodium bicarb. You have to monitor the urine output so that we see that there is no signs of any kidney failure. Whenever you have any suspicion of malignant hyperthermia, always you have to do biopsy. Now you know for biopsy you have to give anesthesia. Over here, the anesthesia which we prefer in time of biopsy is going to be local or regional anesthesia. During this procedure, mild hypothermia has shown to be beneficial. So this is in a nutshell all about malignant hyperthermia. Next guys, whenever we talk about anesthesia, you need to know the American Society Anesthesiology ka classification. The classification is from 1 to 6, in which they will tell you what grading do they give with what disorders a patient is suffering from. If you have ASA class 1, that is a normal healthy patient. ASA class 2 is patient who is having mild systemic disease without any functional limitation, which means he is having hypertension or diabetes, but it is controlled, so he can do whatever he wants with respect to physical activities. ASA class 3 is they have a moderate systemic disease with systemic limitations, which means if a patient has chronic kidney disease or if a patient has liver disease, due to which there are some activities which they have to avoid. Okay, ASA 4 is when they have a severe systemic infection, severe systemic disease in which there is a constant threat to life, like maybe a patient had a history of MI, unstable angina, or a recent cardiovascular cerebrovascular incident. ASA 5 is a moribund patient. Moribund patient is someone who now you know within a couple of time, exactly within 24 hours, he might pass away. So that is ASA class 5. And ASA class 6 is already a brain dead patient. When GCS score is around 3, that will be a brain dead patient. So ASA 1 completely fine. ASA 2 has a disease but it is controllable. ASA 3 is he has a disease but it has some functional disabilities. ASA 4 is a severe disease in which there is a constant threat to life. ASA 5 is moribund patient, and ASA 6 is brain dead. You need to know these all things. Remember guys, whenever you talk about the CB, the hemoglobin level at which usually they say that okay, the anesthesian can give an approval is going to be any value more than 8 milligram per deciliter. Okay, 8 gram per deciliter. Now guys, according to the guidelines, there are 3 types of statement with respect to cardiac patient, or in general you will talk about what is the meaning of in general word, what is the difference between emergency surgery, urgent surgery and time sensitive. So if you talk about emergency surgery, as you see emergency, a longer word which means a more dangerous thing. So remember, within 6 hours you have to do something, otherwise the risk of death in this patient is going to be high. Urgent surgery, a shorter word, so then less risk, so then 6 to 24 hours you can give the time frame for doing the surgery. Time sensitive is if you delay it for more than 1 to 6 weeks, it can have adverse reactions such as onco surgeries or in case of onco treatment. So this is the difference between emergency. Remember, emergency, a bigger word, more dangerous, so do it fast. Urgent, little small, so 6 to 24 hours, and time sensitive, in which if you take a prolonged time, the prognosis of the patient is going to be poor. Now, whenever you talk about what are high risk surgeries, know that intraperitoneal, intrathoracic, or suprainguinal or any vascular surgery which is included, these are considered as high risk surgeries. Along with that, if your patient has a history of ischemic heart disease, history of congestive heart failure, cerebrovascular disease, diabetes, or if the creatinine level is more than 2, these are all predictors of post-operative cardiac complications. So these are the factors which will be there. They asked this in INI, so make sure that at least you have read this. Basically what they're saying is anything which is very dangerous: thoracic, intraperitoneal, subinguinal, patient who's having uncontrolled diabetes, creatinine level more than 2. These are the risk factors in which the cardiac failure chances are more in case of post-operation. Alright. Now another PYQ they asked with respect to cardiac operations was that what about coronary stents? If a patient has a history of a placement of a coronary stent, when will you do the elective surgery? Now that will depend on whether it is going to be a bare metal stent or whether it is going to be a drug eluting stent. If you have a patient who has a bare metal stent, you will ask the patient to delay the elective surgery for more than 30 days. While if he has a drug eluting stent, you will ask them to delay the surgery for by up to 6 months. So that is the difference which will be there. As I said you, the coronary stent will be of 2 types. One will be a bare metal stent, other one will be a drug eluting stent. Bare metal, ask them to wait for 1 month. Drug eluting stent, ask them to wait for 6 months, in case of elective surgery. In case of respiratory disease, guys, if a patient is going up to for the surgery, if a patient has an upper respiratory tract infection, you will ask them to postpone the surgery for up to 6 weeks, give them bronchodilators, corticosteroids or any antibiotics so that they can treat the infection and proceed with the surgery. Remember, you have to wait for up to 6 weeks. Okay. Now they will ask you what are the pre-medications or pre-operative instructions. Like as we told, right, if you have a patient who is okay but we have to improve, what are the things you do? First thing is, what are the drugs will you give to reduce the anxiety? You will give benzodiazepines. Okay, you're going to give benzodiazepines. To decrease the chance of aspiration, you know that we have to ask them to stop the fluids and solids at what time? In children, you have to stop the solid by before 6 hours, breast milk by 4 hours, and liquid by 2 hours. Okay, in children, you have to stop and to prevent the risk of to prevent risk of aspiration, solids by 6 hours, breast milk by 4 hours, and liquid by 2 hours. On the other hand, solids in case of adults will be stopped by 6 hours, whilst liquid will be stopped by 4 hours. This has been asked multiple times in the Fmge exam. If you have any case in which, in case of emergency surgery, if you have to decrease the risk of aspiration, you're going to give a drug which is your metoclopramide. Okay, metoclopramide is going to be given. To reduce the secretions, you can either give atropine or you can give glycopyrrolate. Okay, you can either give atropine or glycopyrrolate. To control infection, you have to give antibiotics, correct? And now question is, when do you give antibiotics prior to surgery? It is given 30 minutes prior to surgery. To provide analgesia, which means painkillers, you are going to give opioids. And to reduce nausea, we're going to give, what is the drug of choice? That is going to be antiemetic. And which antiemetic? We're going to give ondansetron. Okay. Make sure you guys know these topics because these have been asked previously in the exam with respect to anesthesia. Okay. Next, guys, what you have to know is what are the monitoring standards with respect to anesthesia. First thing, according to its like guidelines of American Society of Anesthesia, you need to know what are the parameters you have to check whenever you go before in the pre-anesthetic checkup. Things like blood pressure, in which you include the systolic, diastolic, and meal. The basic things which you do like pulse rate, heart rate, ECG, SpO2, and end tidal carbon dioxide is also checked. Okay, very important. Along with temperature, these are the factors and these are the parameters which you have to check and include in your chart. In base of depth of anesthesia, whenever you're giving anesthesia, there are planes, whether it's going to be in a deeper plane or in a lighter plane. So what we want is we have to have an adequate plane in which the patient does not feel anything, does not like there will be no sensation of pain or there is no sensation of increase in workload in the body activity. So how are the signs of lighter sensation with help of anesthesia? Usually general anesthesia is quite complicated, right? So now you have two aspects when you will have general anesthesia. If you have a patient who is having general anesthesia with a muscle relaxant and you think that the patient is in lighter pain, signs like unexplained raised in blood pressure, tachycardia, sweating, lacrimation can be signs of lighter pains if a patient has general anesthesia with muscular relaxant. If a patient has just general anesthesia, no muscular relaxant, and has spontaneous breathing, you will see eye movements, eyelash response, tachypnea, and you will see the patient is also coughing with laryngospasm. These are the symptoms of lighter plane. So know when the patient is with GA with muscular relaxant, what are the symptoms, and what are the symptoms when the patient is with GA and spontaneous breathing. Ketamine, when you're using, you might see the nystagmus might also be there. Now, how do you find the like planes of anesthesia with respect to objective? What are the tests which we can do? These were signs which we saw. What are the tests which we can do? One very important thing which they have asked in the exam is going to be bispectral index, which is also known as BIS. What this does is we are basically going to count the EEG form, the electroencephalogram form, in which we can identify whether the patient is going to be in the deeper plane or in the lighter plane. A latest form which is there, it is known as entropy, which is a more sophisticated method to calculate the depth of the anesthesia. Now, if you talk about the value of the BIS, there are going to be levels which you need to know. The adequate level which we want is going to be 40 to 60. That is the recommended for general anesthesia. If you have anything less than that, that means the patient is going more deep. Anything more than that, the patient requires sedation. So remember the values. If it is the value of BIS comes 0, the patient is flatlined, very deep. 0 to 40 is in the hypnotic stage. 40 to 60 is the recommended stage. 60 to 90 is the patient requires now sedation, and 100, like right now with us, it is fully awake. So no, understand this. They have asked this previously in Fmge as well as NEET PG, that the level which is recommended for general anesthesia in the BIS score is going to be 40 to 60. Next, guys, let's talk about the cardiovascular monitoring. So basic thing which we already discussed: BP, pulse rate, ECG, ETCO2, temperature. Let's talk more about the cardiovascular. Now there are two methods. One is going to be invasive and one is going to be non-invasive. Non-invasive can be the simple ones which we check the blood pressure, which we check the pulse ox, whereas invasive ones which we directly go within the artery. So let's talk about them in a little bit of detail. Non-invasive examples can be pulse rate, heart rate, BP monitoring, and ECG monitoring. On the other hand, invasive monitorings can be if you see intra-arterial blood pressure, which will be invasive blood pressure, central venous pressure, pulmonary capillary wedge pressure, or pulmonary artery occlusion pressure. These are the examples of, you need to know what are non-invasive, that is easy, and then invasive is just decode the full form, you'll understand these are within the artery itself. If you talk about the non-invasive ones, non-invasive, how do you check the pulse rate? If you see in the ECG, count between the RR intervals. Non-invasive blood pressure, the device which we use is the sphygmomanometer. Sphygmomanometer, guys, works in three ways: palpatory, oscillatory, and oscillatory method. Usually they say you avoid automated BP machines in case of AV fistula. ECG lid 2 rhythm stick can be used for seeing arrhythmias. Lid 5 and 6 can be seen for ischemias. Remember, in ischemia you will see there is changes in the ST. What is the appropriate size of a cuff? You need to know this: 1.5 times the limb diameter, and it should occupy at least two-thirds of the entire arm. Remember, if the cuff size is too tight, the blood pressure can be falsely high. If it is too loose, it can be falsely low. If you talk about invasive monitoring, the question they ask is what is the most commonly used invasive artery? That is going to be your radial artery. If a patient is having coronary bypass surgery, the most common artery used is going to be femoral artery. If you see, this is an example of an invasive blood pressure monitoring. In this, you will have systolic blood pressure and the diastolic blood pressure. You know that in the center, you will have a notch, that is the dicrotic notch. What is the cause of the dicrotic notch? It is because of recoiling of the vessel wall, usually the aortic valve, correct? Now, when you talk about the circulatory methods, there will be two tests. One is going to be Allen test and modified Allen test. Allen test is simple. You basically apply pressure on the radial artery with two hands, and then after that you release the pressure and you see there is collaterals. If there is if there is no there is good collaterals, answer is going to be negative. So the test is negative means it's a good thing. Positive Allen test, which means if there is any pallor and there is no collaterals. This is the basic thing. Now modified Allen test, what you need to know is that here the values are ulta. Here if there is no issue, it is going to be positive, and if there is some issue, it is going to be negative. This is the difference over here, and usually this is the thing which people get confused. So modified mein they thought let us try something different, so that is why they did this. Rest you need to know what is the basic about Allen test and this. Both are the tests which check for the collaterals. Okay. Talking about central venous pressure monitoring, JVP, okay, the technique which we use is going to be cylinder technique. In this technique, we use a wire. After that, we use a catheter, so that a wire gives a wave, and then you put the catheter. The size of the central venous set is going to be important. That is going to be 7 French, and it is going to be 20 centimeter multiport. The most commonly used vein is going to be the right-sided internal jugular vein because less chances of pneumothorax and it is less tortuous. If you talk about the normal CVP or the JVP pressure, it is going to be 0 to 5 centimeter of water. What does the actual CVP value indicate? It is going to indicate the right side function of the heart. What are the conditions in which you see a raised JVP will be there? Any issue with respect to the right side of the heart, for example, if there is right side heart failure, if there is tricuspid stenosis, if there is pulmonic stenosis, if there is pulmonary artery hypertension, or if there is fluid overload, you will see conditions like raised JVP. If they'll ask you which is better for rapid transfusion, now CVP directly gives you a line. Along with that, if you see in fluid resuscitation, we talked about a 16 gauge cannula. Obviously, a 16 gauge cannula, which was the gray color, is going to give a fast method. That is why it is the choice in case of fluid resuscitation. When can you use a CV catheter? It can be used for if you give inotropes or total parenteral nutrition. All right. So this is all about CVP monitoring. If they will ask you what are the other sites in which you can do the CVP monitoring, there can be the left internal jugular vein, but the side effect over here is there is increased chance of damage to the thoracic duct and the pneumothorax. Subclavian, S for subclavian, S for surgeons. So subclavian like to do this through the the surgeons like to do it through the subclavian route, but there is maximum risk of pneumothorax with this method. Femoral, increase of chances of infection. Axillary, the patient will be uncomfortable. If they'll ask you how do you confirm the lining of the cylinder technique is, you have to do an X-ray. In the X-ray, you will see that our catheter is placed parallel to the superior vena cava, just below the clavicle ka inferior border at the level of the third thoracic vertebra. If you can see over here our catheter is over here, right side. So this is going to be right-sided internal jugular vein. You can see it is just below the inferior border of the clavicle. It is within the superior vena cava and approximately at the third level of the thorax. Okay, thoracic over the third level of the rib at the level of T4, T5 vertebra. Okay. If they'll ask you guys, if you see the JVP is low and along with that the blood pressure is low, which means the venous return is also low and the blood pressure falling is low. So if venous return is low, most probably there is hypovolemia, can be associated to trauma or something else. If you have a very high venous return, that is why you will have high central venous pressure or high JVP, and still you are having low blood pressure, which means the heart is congested but not able to pump. So it can be pump failure, which can be either right-sided or left-sided. Here are points, here are conditions in which you should know whether these conditions are increasing the CVP or which are decreasing the CVP. Remember guys, CVP is also your JVP. It's the same thing, okay? Conditions like fluid overload, congestive cardiac failure, pulmonary embolism, cardiac tamponade, constructive pericarditis, pleural effusion, hemothorax causes increase in JVP. On the other hand, if you have hypolipemia or shock, if you have spinal or epidural anesthesia and general anesthesia, these can cause falling down of JVP. Remember guys, if usually the JVP is decreasing in inspiration, but if the JVP is still increasing in inspiration, that is known as Kussmaul sign. Kussmaul sign can be seen in 3 conditions: constrictive pericarditis, restrictive cardiomyopathy, and third one is going to be correct. right-sided heart failure. Now guys, we studied about JVP or CVP, that was the checking the functionality of the right side of the heart. Now let's talk about pulmonary capillary wedge pressure, which is going to check the functionality of the left side of the heart. Indicates left-sided heart function. Okay, so it's going to indicate left-sided heart function. The normal value, if you see, first you'll talk about the size. The size is going to be between around 7 to 9 French, and the normal value is going to be 12 to 18 centimeter of water. Okay, 12 to 18 centimeter of water. And if they'll ask you what is the catheter used, the catheter for pulmonary capillary wedge pressure, which checks the left side of the heart, is the Swan's catheter. Okay, and again the passage is going to be same via the internal jugular vein, and then it follows the pathway. So it goes from the right atrium, right ventricle, pulmonary artery. From there comes to the pulmonary vein and the left side of the heart. Okay, if I talk to you about the monitoring system of the respiratory, first we are going to see the pulse ox to see the SpO2. Correct. Now a very important is what is the principle behind checking of pulse oximeter. Pulse oximeter works behind the principle of Beer-Lambert law. Okay, over here now you need to know what lights are reflected by which type of hemoglobin. You know there are two types. One is going to be oxyhemoglobin and deoxyhemoglobin. Deoxyhemoglobin can also be remembered as reduced hemoglobin. So remember, whenever you are having red light, okay, 660 nanometer R for red light, R for reduced hemoglobin. 940 nanometer is going to be infrared light, which is going to be absorbed by oxyhemoglobin. So oxyhemoglobin, infrared, R for red, R for reduced hemoglobin. Reduced hemoglobin is deoxyhemoglobin. Remember the value for reduced hemoglobin, it is going to be 660 nanometer, and for infrared it is going to be 940 nanometer. What are the limitations for pulse ox? Now you know there are severe conditions. If a patient is severely hypothermic, if a patient is shivering, if a patient has hyperpigmentation, nail polish, you will have inaccurate or you won't have a reading at all. So remember conditions like cold, shivering, severe anemia, nail polish, hyperpigmentation, shock, these conditions will give why the values are not reliable. Remember, if you have any poisoning like carboxyhemoglobin, you will have a falsely elevated SpO2 value, while if you see methemoglobin gives you a falsely low hemoglobin. If you have a patient who have fetal hemoglobin or any other form of hemoglobin, there will be no change in the pulse ox. So this is what you need to remember with respect to pulse oximeter. Remember what type of principle it falls? Beer-Lambert law. Okay. Now let's talk about the last topic for today, that is going to be capnography. Capnography is a graphical representation of the exhaled carbon dioxide. Why do we use it? We'll see over right now over here what are the advantages. But before that, you need to know what it is. The normal value first of EtCO2 is 35 to 45 mm of Hg. It basically checks the adequacy of ventilation. How is it going? Is it good or bad? What are the advantages? Capnography, guys, is the surest sign for intubation. The best sign for intubation is going to be surest sign, which is your capnography. It can detect venous air embolism. It can also detect how nicely are you doing the CPR. If we already talked about this, that it is raised in case of malignant hyperthermia, so it can also be used in the diagnosis of the malignant hyperthermia. It can be used to diagnose any circuit disruption in case of the anesthetic machine, the Boyle's machine, and also to identify any types of bronchospasm. If they'll ask you what are the principles, it has a main principle of diverting and non-diverting type. There are two words which you should know. One is a capnometer and a capnography. Capnometer is something which is measuring the exhaled carbon dioxide, whereas capnography is something which is going to be a graphical representation of the exhaled carbon dioxide with respect to time. Over here, guys, this is the capnography. It is like a hat shape. It has 4 phases. 1, 2, 3 and 4. Phase 4 is also known as phase 0. First thing you need to know is this is going to check, this capnography is checking what? It is checking exhaled carbon dioxide. So after I inhale part, now it is going to come the exhale. Over here you have 4 phases, phase 1, 2, 3 and 4, where phase 4 is also known as phase 0. So when you talk about removal of air, first thing, if you talk about the conducting part, the whole respiratory system, you know the upper part is the conductive airways. In this conductive airways, you know there is anatomical dead space. So first the air is going to come out from there, but in this air there is no carbon dioxide. That is why the first phase over here is going to be plain, it's going to be flat line. Okay, then now the carbon dioxide is going to come out from the upper lobes. That is why you're going to have a sudden upstroke will be there. So gases are exhaled from the upper alveoli, so which will be your expiratory stroke. That is phase 2. Phase 3 is in which the air is going to come out from the middle and the lower airways. So that is why you will almost have a plateau, because maximum air was going to be in the upper lobes. After this, when this from the air is going to exhale from the lower airways, then will be the time of inspiration. Preparation for inspiration is going to begin. It is at this point that you are going to check the end tidal carbon dioxide. So after this, the phase 4 is the beginning of the inspiration, at which now whenever you inspire, there will be oxygen rich air and less carbon dioxide, due to which the value of the EtCO2 graph is going to fall, and at proper time of inspiration there will be only 100% oxygenation. That is why you will have a flat line again. So you see there are 4 phases in the capnograph. The first flat phase is because of the anatomical dead space air that does not have carbon dioxide. Then the first peak which will be there is because of the air which is exhaled from the upper lobe. There will be a sudden upstroke. Then you will have kind of a plateau which will be because of the air from the middle and the lower lobe. And then you will have a downward fall because the inspiration is about to start. And during inspiration, there is more oxygen, less carbon dioxide. And when properly inspiration starts, that time it is going to be flatline. So this is your example of your capnography. And over here guys, there are some lines which over here which you have to mug up. Sadly, here you need to remember these values. How do they look? So try to watch these images every day, so you will try to remember it, and you have to remember. So over here you can see the upstroke is kind of more peak, and there is the plateau is also more sharp, which is seen in bronchospasm. Remember, you need to know values like the Cruret cleft. You don't need to know why it is there. Just remember that they'll ask you identify this capnographical image, and you will have to identify it. In case of rebreathing, it looks like this. Esophageal intubation, which means it is not going into the trachea, it is going to the GI. So obviously there is no inspiration, that is why it is falling down. In case of spontaneous breathing, it looks like this. And then there a single lung transplant, and then a malignant hyperthermia, because in a malignant hyperthermia everything is increasing. You can remember it in this way. So what I have highlighted are very important conditions. So make sure you see this at least once and have a regularity at least in those all yellow parts. Remember, it looks like a hat. 4 phases: phase 1, 2, 3, 4. Okay, that is all for this part. I hope you understood. Mostly it is a mugging up topic, but those which we have discussed, that is the only required topic. You don't have to go in too much depth in the topics which have been discussed. If you have any doubts, make sure that you are feel free to text me, and let's see in the okay. So make sure that you see at least the yellow highlighted at least, because these have been asked in the exam. And this is all for today's video. I hope you understood most of them. Again, as I repeated, it's mostly mugging up, but you don't have to go in too much details of anything which we have discussed. It is more than enough, and after which you have to also practice the PYQs. See you guys for the next part. Take care. Sayonara.